Hello, I am Dr. Brandon Brown. I am an attending psychiatrist, inpatient, do interventional psychiatry, do psychotherapy, do it all. I am going to be talking today about distinguishing bipolar disorder, bipolar depression from major depressive disorder. So, unipolar versus bipolar depression. And just getting off work here, heading home. I realized doing these podcast episodes on my commute home maybe is not as good as doing it on the way to work because I'm pretty exhausted from the day, but see what I can do here. So I'm usually inspired by something that happened on the unit, some of the patients that I'm seeing, etc. But I got to be really careful about privacy, right? I can't say anything that would identify a patient to anybody, including, other staff members on the unit, things like that. So I got to keep it pretty vague. But I did want to talk about bipolar versus unipolar depression because I had a patient recently that got admitted for acute mania with psychotic features in the context of being on an antidepressant monotherapy because they had previously been diagnosed as MDD and were in a depressive episode and then, flipped into a manic episode in the context of this antidepressant. Anyways, they got better. They were on, mood stabilizer, antipsychotic. They got better and they were a little bit upset that this had happened, that they were on an antidepressant that probably increase the probability or potentially worsen the severity of this manic episode. And so wanted to kind of talk about how this could have gone differently. If it could have gone differently, was there any way for their psychiatrist outpatient that started them on this antidepressant to have known better, to have not done that? So in this case, was someone who had had multiple major depressive episodes over the past 10 or so years, but no history of manic episodes, no history of hypomanic episodes. So according to the DSM, you would have had to diagnose major depressive disorder because if you have recurrent major depressive episodes, so fulfilling those SIGI caps symptoms, then that's what you got to diagnose with. Anytime someone shows up in the hospital or in the clinic with depression, you've got to come up with your differential diagnosis for depression. That could be adjustment disorder. Did something bad happen in their life and they're responding to that bad thing? Is it a medical cause? Are they, hypothyroid, or did they get put on a steroid, or are they anemic, or whatever else you could imagine it being? Is it a mood disturbance due to post-traumatic stress disorder? Or could this be really some sort of primary psychotic disorder like schizoaffective disorder or schizophrenia? And then, of course, most of the time you're thinking about major depressive disorder and bipolar disorder. So most of the time, those are the kind of two differentials that you're debating between. And in this case, this is someone who, if you're going by the books, you really could only diagnose major depressive disorder. But is there something that we could have, were there any clues that might have given us a hint that, oh, maybe this is actually someone with bipolar disorder? So I want to talk about some of those potential clues. Probably the biggest one is family history. So if you've got someone that's coming to you, they're in a major depressive episode, they've got no history of mania or hypomania, and you're pretty sure of that based on a good interview and maybe even getting collateral information that something like that's never happened. Do they have a family history? Do they have like a brother or a sister or a mother or father or someone, not too distant in the family tree with bona fide bipolar disorder? That obviously should raise your suspicion, and you should be more careful about prescribing monotherapy antidepressants. the other thing to keep in mind is that mental health disorders don't breed true. So that's to say that if you have two parents with, say, schizophrenia or two parents with, say, bipolar disorder, the children may not get the same disorder as the parents. They may end up with a different kind of serious mental health condition. Maybe they get severe OCD or, severe bipolar disorder or something like that. So just taking note of any severe mental illness in the family should sort of raise your suspicions that this could be more of a bipolar depression potentially. Other things to consider are age of onset. So if someone gets their first episode of depression like in their teenage years, then that should raise some suspicion as well. And then poor response to antidepressants. So if someone's been on a couple of different antidepressants and maybe they've gotten a little worse, maybe they had some agitation, they've had, particularly bad side effects from it, and they're definitely, not getting any better, then that should raise your suspicion as well. Other things, are they having very highly recurrent episodes of depression with clear periods of euthymia in between? So is this a very pattern, they've got, a month or two of a major depressive episode, and then they get better and they're totally fine for a while, and then they have another episode, and it may or may not have provoking factors that kind of trips off the episode. That is also more likely to be potentially bipolar disorder. And Emil Kraepelin, the German psychiatrist from the 1800s or so, he kind of categorized, this distinction between MDD and bipolar disorder was not there. It was under a single spectrum of manic depression. And some folks might just have depressive episodes. Some folks might just have manic episodes, and most of the folks would have both. I should point out that in bipolar disorder, there is a concept of unipolar mania. So you can have bipolar patients that never have depressive episodes and they only have manic episodes. And I just don't see how it's biologically plausible for there to be a distinction between MDD, a categorical distinction, I should say, between MDD and bipolar disorder. How could you have just a category of people with a mood circuit that can only break in one direction? It can only get depressed and be depressed or euthymic. And then you have a different category of people where it can get depressed and manic and euthymic. I just think that's biologically implausible. I think more likely the mood circuit can break in both directions for everybody, and there's just a difference in probabilities. So because there's everybody has a negative affect bias, meaning that we're always more sensitive to loss than we are to gain. We're more prone to sadness than we are to happiness. There's just an asymmetry there for evolutionary reasons, because you only get to play the game of life once. So it's better to protect yourself from total ruin and total loss and be sensitive to that kind of catastrophic risk than it is to constantly chase the next best opportunity and get overexcited about, some new opportunity. So in general, there's a bias toward depression in general. So I think that goes a long way toward explaining why depression is more common than mania. But anyways, yeah, I would just argue that I'm not so convinced that MDD and bipolar disorder are categorically distinct disorders like the DSM makes them out to be. And I, as a psychiatric practitioner, as a practicing psychiatrist, I don't really think clinically in those terms. When I see a patient with depression, I'm thinking more probabilistically and based on risk. So of course I'm going to be doing a good interview. I'm going to see if they've had an episode of mania or hypomania in the past, or, go through all the criteria for depression, etc. But it doesn't end there where I just say, okay, they've had a major depressive episode. They've never had a manic episode. Therefore, it's MDD. Let's start them on, Lexapro. I'm going to be looking for those risk factors, and I'm going to also be paying attention to the severity of the condition. I talked a little bit about this in the episode on treatment-resistant depression. So, I think that's also something that can be helpful in not just throwing someone on an antidepressant monotherapy. If someone's coming to you and they're in a severe major depressive episode, but they've never had an episode of mania before, maybe it's not a good idea to just put them on an antidepressant monotherapy and wait 4 to 6 weeks for it to work, especially if you've got some of those other risk factors for possible future manic risk. Oh, another thing I just remembered, demographics are important too. So when do people tend to go manic for the first time? Well, usually it's like late teens, early 20s, maybe up into those early 30 years. So if you're kind of in that, especially the early 20s range, I'm also pretty careful about, is this the right person to be putting on an antidepressant monotherapy? If I'm seeing someone who's 50 or 60 and having their first major depressive episode, then pretty unlikely to be going manic. Not impossible, but just less likely. We're all dealing in probabilities here. So that's kind of how I think about diagnosis and treatment. And so I would just argue that we need to have more of a risk-based, probabilistic framework for diagnosis and treatment, and not just shut down at this is MDD. For the patient that I'm thinking of, they had multiple recurrent depressive episodes, kept getting tried on different antidepressants, still having severe major depressive episodes, highly recurrent, no clear provoking factors. They had a perfectly good life. They're not traumatized or any other thing. I'm starting to think, this is maybe a more manic depressive bipolar kind of pattern here, and we should be moving in that direction in terms of our treatment. I should also point out that there is so much overlap in the treatment of major depression from, or I should say unipolar depression and bipolar depression, that, even the treatments themselves don't really point to these being categorically different diagnoses. Almost all of the medications that are well studied and show efficacy for bipolar depression also show efficacy in major depression, unipolar depression, either as augmentation agents or as monotherapy. Thinking of things like Symbyax, which is the olanzapine fluoxetine combination, or quetiapine, or Abilify, aripiprazole. It's FDA approved as an augmentation agent for major depressive disorder, but I've found it pretty effective for bipolar depression as well at low doses. Some of the studies at high doses showed it was ineffective, or talking to like 15 plus milligrams, but at low doses, 2, 5, maybe 7.5 milligrams seems to work just as well, at least in my hands anecdotally. So the treatments between unipolar and bipolar depression don't really suggest a major difference either. All right, well, I think that's pretty much what I wanted to say about the distinction between unipolar and bipolar depression. If you have any input or want to push back against that, feel free to email me at brandon@outlace.com. That's BRANDON @OUTLACE.com.